Then I will I will do it both the right and left side to get some idea is there any weakness present or not. Or if someone want to say the weakness in MRC grade, then I can do it. But it will not give any specific idea to me. Then what I will do, I will check the thigh muscle at first. So I will check the thigh muscle. For that reason, I will ask the patient, push your thigh up and don't let me push it down. So I will place my hand over the thigh and ask the patient, push your thigh up, don't let me push it down. Now I will now I will place my hand just below the thigh and say, please push it down, push down. Okay, so I have examined the patient thigh up and thigh down. Now I will check the patient. I will ask the patient knee to bend. So I will ask the patient knee to bend, and I will place my finger over the both lateral aspect. Okay, so I have examined the hip joint, that is flexion and extension power, and now I am going to check the abduction and adduction. So I will flex both of the knee joint, and then I will place my hand beside lateral aspect of both knee joint, and I will ask the patient. I will also push my hand or try to separate your knee. Don't let me close it. So push my hand or try to separate your knee. Don't let me close it. Okay. Then by this way, I can check the abduction power. Now I will check the adduction power. Again, I will place over the medial aspects and say push in my hand or try to close your knee. Don't let me separate. So I have checked the thigh. So both flexion, extension, and abduction and adduction. Now I will check the knee joint. So just patient leg will be flexed, and I will just hold the patient ankle. I will ask the patient, please pull your legs towards your buttock. I will say, just pull your legs towards your buttock. Okay. Then I will check the knee flexion. Now I will place my finger in the front of the leg and say, push your leg down. Push your leg down. So I will say extension of the knee joint. So I have seen the flexion and extension of the knee joint. Now I will check the ankle joint. To see the ankle joint, I will just place my hand over the finger or the toes, and then I will ask the patient to push me down. And I will again place my hand over the dorsum of the toes and ask the patient to pull me up. Okay. So in this way, I will examine the patient power. Now I will check the patient reflex. In case of the reflex, before doing the reflex, I always say, look, this is a hammer. This is made of rubber. I will tap it different parts of your leg. Don't worry, it will not be painful. If you feel any pain, let me know. Then I will check the knee jerk, ankle jerk. So before doing reflex, I will say, look, this is a hammer. This is made of rubber. So I will tap it different parts of your leg. It will not be painful. If you feel pain, let me know. Okay, then I will check the knee jerk. Then I will check the ankle jerk. Now I will check the plantar response. To see the plantar reflex, at first, again, I will do some orientation. I will find there is a stick with sharp head. I will pick up the stick and I will say, look, this is a stick. So I'm going to scratch in your sole. It will not be painful. If you feel any pain, let me know. Okay. Then I will see the plantar response. Okay. So again, before plantar response, I'll say, look, this is a stick. I'm going to scratch in your sole by this stick. If you feel any pain, let me know. Okay. So by this way, I will check the reflex. Now, what I will do, I will check the coordination. Okay. So I will check the coordination. To see the coordination, I will ask the, please place your heel over the knee and drag it down to the ankle. Place your heel over the knee and drag it down the ankle. Then I will say, just do it in the other side. So in this way, I will see the coordination. After that, I will check the sensation. For the sensation, usually there is a pain sensation, there is a touch, and dorsal column. To see the dorsal column, usually you can see the vibration or position. See, if I think that I have enough time, then I will do all of that. But if I think that I don't have enough time, then I will do one from there. In this case, I will check the pain sensation. Then in case of the another way, we will check the vibration. From the dorsal column, we will check the vibration. And from the anterolateral column, we will check the pain. So I will take the neuro trip. To see the pain, there is usually a neuro trip there. So I'll look, this is a neuro trip. So I'm going to scratch it over your chest. In any patient, I will not touch this neuro tip to the face. It is always in the chest, okay? Because in case of the vibration, you can place the tuning fork over the forehead, but in case of the neuro tip, we will always in the chest. So look, I'm going to scratch it over your chest. Then in case of the female, we have to be careful. Then I will touch the neuro tip. Can you feel it? The patient will say, yes, I can feel it. Okay, I'm going to touch it over different parts of your leg. If you feel, please let me know, okay? Now I will ask the patient to close the eye. If we don't ask the patient to close the eye, it's also okay because we always trust the patient. But the thing is that sometimes patients do misperception. When I go to the patient leg, patient may say yes. So for that reason, what I will do, I will ask the patient to close your eye. Then I will ask the patient to please close your eye. Then I will touch the neuro tip, the different parts of the leg. If the patient say yes, then I will say the opposite of yes. And then yes, yes. Then after 2 or 3 times, I will easy similar to your chest. The patient will say yes most of the time. Okay. Then if I want to the touch, then I will do it by cotton stick. By the same way. Now, from the dorsal column, I will check the vibration test. So look, this is a tuning fork. I will just place the tuning fork. First I will take the tuning fork and I will make the tuning fork to a buzzing by a scratch or by holding the upper tip. Then I will place the tuning fork. Look, this is a tuning fork. I'm placing the tuning fork in your chest. After placing, I will say, can you feel the buzziness of this tuning fork? Patient will say, yes, I feel it, which is buzzing. Okay. I will place the tuning fork over your legs. Then please close your eye. Then patient will close the eye. I will place the tuning fork over the index finger. Oh, so over the great toe. Then can you feel it? Yes. Then I will do it in the other side. Can you feel it? Yes. So in this way, I will check the sensation of the dorsal column. That is vibration sense. So if I want, I can also check the position change. So I will do it in the great toe also. So I will hold the great toe. Then look, this is up and this is down. Or I can say only it does not necessary to lift the leg because it's a positional sense. So look, this is a down, this is a up. We will always hold the finger from the side to side. So then please close your eye. Where it is down or up. Patient will say it is up or down. So this is the way I will do the examination. So what I done as far I will do the inspection, and then I have checked the tone, the power, reflex, and I have also seen the coordination and sensation. That is pain, touch, and dorsal column, vibration sense, position sense. If I don't have enough time, I will say only the pain by neurotips and dorsal column from vibration by the tuning fork. Okay. So what I miss here? I miss the clonus test. If we find that patient is actually when we see the tone from my movement, then we will observe the clonus. In case of the paces, usually if you see the ankle clonus, that is sufficient. So when we see there is a spastic and when we see the movement by movement, tone by the movement. That is why then we will observe the clonus automatically. So we don't need to see the plantar clonus. So we only see the ankle clonus. Okay. So we have what we have done. We have done the motor system, and we have also done the sensory system examination. Okay. So, okay. So anyone have any question up to this regarding examination?
Yes, sir. Regarding sensory system, you said pinprick only is sufficient, or soft cotton wool also we have to do?
Yes, it depends on the time. So if you take enough time in the motor system examination, so it is better to do the one from one. Because if you think that everything is going to the spastic paraparesis with definite sensory level, then you have to go to the back. So if you think that time will not allow you to see the back, then just you will do one from the one. From the anterior column, for only the pain sensation. From the dorsal column, just choose the vibration sensation, because it is more reproducible.
Doctor, why do we need to do the cotton wool? What's the significance? What will it tell us?
Sorry?
When we're doing the cotton wool crude touch, what will it add to our findings?
Good question. It does not add anything new in our findings. Okay, so now I will going to tell actually what we have observed in these findings. So what we have observed already. Actually, in any case, in the lower limb examination, our aim was to see some motor finding, to see some sensory finding, and in between motor and sensory, I will check the cerebellar. So motor finding, sensory finding, and cerebellar. So what we have, we examine the motor system. Okay, so motor system, that is just inspection. Then we have checked the tone, power, reflex. Okay, so inspection, tone, power, reflex. So those are actually the motor system findings. So motor system finding actually tell us whether the lesion is upper motor neuron lesion or lower motor neuron lesion, or as a general cause, what is the type of the lesion. Now, after that, we examine the sensory system. That is, we have examined the anterior column and also the dorsal column. So if anyone has any sensory lesion, then we can say actually where is the lesion. Okay, if it is sensory system is the dermatomal distribution, then we know that this is a peripheral nerve lesion. If the sensory system is affecting both sides symmetrical, so we know this is a spinal cord lesion. So sensory system examination actually tell us where is the lesion. So at first we will do the motor system examination. So motor system examination actually tell upper motor neural lesion or it is a lower motor neural lesion. Then we have examined the sensory system. Sensory system examination will tell us where is the lesion. In between motor and sensory, when we examine the coordination, actually we have examined the cerebellar system at that point. So we have examined the cerebellar at that time. When you see the coordination. Now, when we say the finding, we have to say all those things in a separate manner. So that it will be a meaningful one to point a diagnosis. Okay. So what we have examined, motor system again, sensory system, and cerebellar. So we will say all those things in three different parts. So now I'm going to the case that is spastic paraparesis. So it's a very common case, spastic paraparesis. See, in case of the spastic paraparesis, paraparesis. So this is the spastic paraparesis. Always is a motor finding. It is a output of the motor system examination. So when we say the spastic paraparesis, always we have to say the sensory along with that. So spastic paraparesis is not any finding without any sensory. So when we say there is a spastic paraparesis, actually we will not say that. We will not say spastic paraparesis with definitive sensory loss, spastic paraparesis with anterior column lesion, or spastic paraparesis with dorsal column lesion, or spastic paraparesis without any sensory loss. So I will say spastic paraparesis in various ways. First of all, spastic paraparesis without any sensory loss, So what I will say, just I will say on examination of this gentleman. So I have examined the patient, the gentleman. I will say on examination of this gentleman, at first I will say, is there any wasting, scar, fasciculation, abnormal lip posture? I'll see the surrounding, any walking aid, on a specialized shoe or not. So examination of this gentleman, but most of the time, if there is pain for positive, I will not find anything. Just I will go to the second part. Okay. So on examination of this gentleman, inspection finding. If there is no inspection finding, I will go to the next. Okay. There is a symmetrical weakness of the both legs. Okay. So there is a symmetrical weakness of the both legs. After that, actually, here I will stop and I will say something where I have to, in this weakness, I will differentiate. In this weakness is upper motor neural lesion or lower motor neural lesion or any myopathy. Okay. So how we will differentiate? In case of the upper motor neural lesions, if you see the stroke patient, what's happened? Usually leg is straight. So there is a straight leg. So that indicates there is a weakness of the flexor muscle. So in case of the upper motor neural lesion, what we found its leg is straight. So that is a weakness of the flexor muscle. Okay. And as there it is a neuropathy, so there is a distally will be more weak than proximal. So more distal weakness. So more distal weakness. And as well as I have found there is a more flexor involvement. Okay. And in case of the myopathy, actually what's happened in any myopathic patient, actually what we say, there is a frog-like distribution that indicates patient cannot adduct his leg. Okay. Here we found the adductor weakness. So patient cannot adduct. Here the opposite is occur. That is abductor weakness occur. So abductor weakness. So in case of the lower motor neural lesion, again this is the same flexor type of weakness, more distal weakness, and as well as abductor weakness. We just don't need to say everything. Just we will say flexor or distal or proximal. Okay. Sometimes we may confuse it is abductor or adductor. If we found something specific about the myopathy, then we'll say this is a adductor type weakness. Okay. So again, I will say just on examination of this gentleman, there is a symmetrical bilateral weakness of the both leg. Okay. Where distally is the more weak than proximal, and flexor are more weak than extensor, and abductor, if we want to say, abductor is more weak than flexor. All this finding indicate this is a neuropathical, this weakness due to neuropathy. Okay. And there is also hypertonia, as there is I'm saying going to say the spastic paraparesis finding. Then so there is also hypertonia, hyperreflexia, and positive pyramidal sign. If I find the clonus, I will say along with clonus. Okay. And coordination examination is normal, or coordination cannot be assessed due to weakness. Okay. Again, sensory system examinations indicates all modalities of sensation is intact. So my diagnosis, this is a case of spastic paraparesis with intact sensory level. Okay. So in my, I am going to say it again. So my first case is, this is the case of spastic paraparesis without any sensory loss. So what I will say, on examination of this gentleman, I found that if there any scar, fasciculation, or rusting, I'll say it. If no, I'll go to the straight. There is a symmetrical weakness of the both lower leg. Okay. Where distal is the more weak than the proximal and flexor are more weak than the extensor. This indicates it is a neurological weakness. Okay. Again, and there is also hypertonia, hyperreflexia, and positive pyramidal sign along with tonus. Okay. Coordination examination cannot be assessed due to weakness. And sensory system examination of this gentleman reveals all modalities of sensation is intact. So this is a so my diagnosis, I will say here only the clinical diagnosis at first. So my clinical diagnosis, this is a case of spastic paraparesis without sensory loss. So this is a case of spastic paraparesis without sensory loss. So this is a case of spastic paraparesis without any sensory loss. Okay. Now examiner will ask the question actually, what is the cause? Then go to the reason. I'm going to say it again. So my first case is spastic paraparesis without any sensory loss. So on examination of this gentleman, there is a walking aid or there is a wheelchair. And there is a symmetrical weakness of the both leg, where distal is the more weak than proximal and flexor are more weak than extensor. Okay. There is also hyperreflexia and hypertonia and positive pyramidal sign along with the clonus if present. Apart from and coordination of this gentleman is cannot assess properly due to weakness. And sensory system of examination of this gentleman reveals all modalities of sensation is intact. So my clinical diagnosis, this is a case of spastic paraparesis without any sensory loss. Then if we see the, if we see the mark sheet, then we'll find that marks is distributed in differential diagnosis. So in every case, we have to know the clinical diagnosis as well as differential diagnosis. Then appropriate management plan. And okay. So most of the time, if we find the findings in the case, usually we'll secure more than 15 marks. Then they will ask the question actually, what will be what is your clinical diagnosis? What is the differential diagnosis? How we are going to investigate this patient and how we are going to manage this patient? They can ask many other questions apart from this, but most your mark is distributed in those 4 questions. So what is your clinical diagnosis? Spastic paraparesis without any sensory loss. Then I will ask the differential diagnosis or the cause. Here they will ask the cause. So if you see the spastic paraparesis in then the examiner will say the cause. The first cause is most of the time we'll found this is a cause of cause may be vary from country. Most of the time this is a case of, I will say that's motor neuron disease, but they had usually multiple sclerosis, and in case of the parasagittal meningioma, recurrent stroke or multiple stroke. And another thing is in spinal cord hereditary spastic paraparesis and tropical spastic paraparesis. So those are the common cause, that is spastic paraparesis without any sensory loss. So again, this is a motor neuron disease, multiple sclerosis, parasagittal meningioma, recurrent stroke, hereditary spastic paraparesis, and tropical spastic paraparesis. So those are the common causes. Yes, sometimes in case of tropical spastic, you can find the sensory sign, but not always. So I will say those this multiple motor neuron disease, MS, parasagittal meningioma, recurrent stroke, hereditary spastic paraparesis, tropical spastic paraparesis. Okay, so this is the then examiner will ask the question. So our main aim here is MND, MS, parasagittal meningioma, and recurrent stroke. Now, I again go back to the examination of the patient, because in every time, if I get some time, I'll do some additional thing. Okay. So now think, if any patient comes with the spastic paraparesis without any sensory sense, so what I will do next? Next, I will do check the back. Okay. Why back? It's as usual. It's a usual procedure. So I will check the back first. Then yes, I have another time. I will go to the upper limb. I will go to the upper limb only to check 2 or 3 sides. Just I can check the jerk only. Okay, or tone. Chest. Then I will check the patient tongue to see any fasciculation. Okay, so so again, examiner asked, or there is a direction then to examine the patient lower limb. But if I have enough time, then I will go up. Okay, so this up is only depends on the cause. So in the lower limb examination, I find there is a spastic paraparesis without any sensory loss. I will immediately check the back. I will roll the patient. I will check the back. Okay. And another interesting thing is that if any patient is MND, comes in the exam, we'll found there is some weakness, only the weakness. And again, in another patient, most of the patient here will not comes with the will come with some form of weakness, not plasias. They comes with the weakness. So I'm saying this weakness, and MND patient comes with the weakness. Okay, so just I will ask the patient to roll. Patient will roll, and I will check the patient back. Then I will go to the patient upper limb. In case of the upper limb, just I will see 1 or 2 signs. Just I will say the reflex, or I will say the tone. Just I am going to check the patient tongue. There are a lot of things to do, but I'll try to do this. Okay. So in case of the MND, I can get some clue. Okay. So now examiner will ask the question, what investigation you want to do. In case of the investigation, as is my first, I think it's a maybe spinal cord problem. And here my first diagnosis is MND. It's actually clinical diagnosis. So we can do the EMG here. And in case of the spinal cord, I will do MRI of the spinal cord. Here is also recurrent stroke. So I can check the patient MRI of the brain also. And for the MS, I will do CSF test for unilateral band. I can do the visual evok potential. Okay. So again, for the hereditary spastic paraparesis, I can do some form of, I can take the family history. So if you say the investigation, so what investigation you will do? Just look at the cause and say 1 for each. You can say in the other way that first I will do some basic investigation like every patient, but here it's totally different. So better to say to see the MND is mainly the clinical diagnosis. Just I will exclude the other thing. If anyone say what is the most common differential diagnosis of MND, that is cervical myeloradiculopathy. For that reason, you will do if you do the MRI of the spinal cord or brain. So actually, we will exclude recurrent stroke or any brain spinal cord pathology. And in case then I will say that for the multiple sclerosis, I will do the CSF to see the unilateral band. I will do the visual evok potential. For MND, I can do the EMG. For hereditary, I will take the family history. So this is the case regarding. And now, lastly, will be how will you manage this patient? For this management, Actually, I have, I will say two. So some general management, that is patient education, counseling, formation of the multidisciplinary team that involve my consultant, social worker, occupational health worker, physiotherapist, neurologist. So regarding the investigation, just I will say one for each. Okay, I will say just MND is mainly clinical diagnosis, so I have to exclude the differential. For that, number one differential for the MND is cervical malodrepopathy. Okay, and I will do the MRI of the spinal cord and brain. If we do the MRI of the brain, just I will exclude the parasitical meningioma recurrent stroke. As well as in case of the MS, I will find some finding of the brain. And another thing is that I will do the CSF study for the oligogonal brain. And for the MS, I can check the visual epoch potential. And again, for the MND, I can also do the EMG. And for hereditary spastic paraparesis, just I can do the some genetic test, family history. So those are the investigation. Last question is, how will you manage this patient? So manage. Regarding the management, in all types, in all neurology, there will be some general management and some specific. So general management, just I will do the patient education, counseling, explanation of the disease, formation of the multidisciplinary team. Okay, that include always my consultant here, neurologist, because I'm saying to the examiner, social worker, occupational health therapist, or occupational health officer. Okay, and here this is the general management. Now I'll say some specific management. Okay, sorry, another thing is a physiotherapist. Physiotherapist. So specific management actually differ from patient disease to disease. Here, examiner may ask some question regarding any specific management. Okay, so here examiner may ask some question regarding the specific management. If you ask the question, what is the management in case of hereditary spastic paraparesis? Actually, no management, only the physiotherapy. Okay, what is the management in MS? Actually, at that time, it actually differs. MND, no management. You can give riluzole, but it increase the patient's survival up to 3 months. Okay, so that time actually vary, and a follow-up of the patient actually is vary. But I will say the general management as well as specific. In that case, examiner will ask a question regarding from anything. Okay. Okay. So this is the spastic paraparesis with without any sensory sign. Now we will discuss the again spastic paraparesis. Now we will discuss spastic paraparesis with loss of sensation. Okay. If you say the finding again, so on examination of this gentleman, there is a weakness of the both leg. So again, so on examination of this gentleman, if you feel any scar, I will say the scar in wasting or something, or I will say directly on examination of this gentleman, there is a symmetrical weakness of the both leg, where distal is more weak than proximal and flexor are more weak than extensor. There is also the hypertonia and hyperreflexion, and there is also a positive pyramidal tract sign along with clonus. Cerebellar system examination reveals, or sorry, here usually in this case, spastic paraparesis with definite sensory sign, we will not find anything. Most of the time we found there is a profound weakness. So cerebellar system examination is not possible, or coordination is not possible to see as there is a weakness. Sensory system examination reveals all modalities of sensation is absent up to the level of umbilicus, or up to the level of thoracic 10, or up to the level of thoracic 8, that is midway between the G4 sternum and umbilicus, or up to the level of the G4 sternum, that is thoracic 6. So I will say in this way. So then I will say this. So my clinical diagnosis, this is a case of spastic paraparesis with definitive sensory sign, okay, or spastic paraparesis with loss of all modality of sensation up to the level of this, or spastic paraparesis with signs of complete cord transection. So I will say this is a spastic paraparesis with loss of all sensation, or spastic paraparesis with complete cord transection, or spastic paraparesis with definitive sensory lesion. So what will be the differential diagnosis? So in case of a spastic paraparesis with definitive sensory lesion, our main differential diagnosis is 4. Mainly, if you remember the 4 T, then it will be easy. That it is maybe due to trauma, it may be due to transverse myelitis, it may be due to tumor, any tumor, or it may be due to TB. Okay, so this is the 4th T. But before that, what we will say? Any cause of dorsal myelopathy. Dorsal myelopathy. What are the cause of dorsal myelopathy here? This. So again, on examination of the gentleman, there is a weakness of the both leg, where distal is more weak than proximal, then flexor are more weak than extensor. And there is also hypertonia, hyperreflexia, and bilateral upgoing plantar response. Okay. And on examination, coordination examination is not assessed as there is a profound weakness. Sensory system examination reveals all modalities of sensation is absent up to the level of umbilicus. So my diagnosis, this is a case of spastic paraparesis with loss of all modalities sensation up to the level of umbilicus. Then we will say what will be the cause? Any cause of dorsal myelopathy, like it may be any trauma, or it may be transverse myelitis, it may be tumor, or tuberculosis. Okay. Sometimes we may get this gentleman has some catheter. So if there is a catheter, then also there is a catheter in situ. So along with that, I can get the catheter. So if I get catheter, I will say this there is a catheter in situ. Okay. Sometimes it's also possible that the finding is not symmetrical as we think. Sometimes you will find that because it depends. It depends. If it is transverse myelopathy, then we prefer all the full picture. If it is tuberculosis, it depends on the extent of the tuberculosis, how it involves. And as well as in case of tumor, if it is intermedullary or extramedullary, there will be some difference. Okay, but in case of the cases clinical station, they will put the case where there is a obvious findings. Usually, most of the case here is as transverse myelitis or any due to trauma, spinal injury, and now he is operated or anything have done, but there is still weakness and leg is not improved. And every time he comes in the X-ray, we say it's the most common thing. So again, if we say that what is the how we're going to investigate this patient, regarding the investigation, I will say the MRI of the dorsal spine. I will say the MRI of the dorsal spine. Yes, I will do the other investigations, but first of all, MRI of the dorsal spine. Then I can specify the investigation. If I find in the MRI there is a tumor, then I will do the CT or guided FNAC. If I case in the MRI there is a possibility of TB, that means if there is a discitis, there is a loss of compression fracture or collapse, there is a vertebral collapse, there is a paravertebral abscess, which suggests the tuberculosis. Then I will do the other thing, that is chest X-rays, put on for ABs, put on for gene expert, MT test. Then I will do the test. But most of the time I will say I will do the MRI of the dorsal spine. Okay. Now regarding they will say how will you manage? Then again, management, I will do the general management and specific. For the general management, that includes patient education, counseling, explanation of the disease, formation of the multidisciplinary team that involve my consultant, okay, nerve doctor or a neurologist, physiotherapist, social worker, occupational health care therapist. And here the patient is it's not catheter or so I will say that I will take the bowel care, I will take the skin care, I'll do the physiotherapy. Okay? And specific management actually depends on the cause. If there is TB, anti-tumor chemotherapy, tumor, do the surgery. Because transverse myelitis, if there is acute transverse myelitis, I will start steroid. So in this way, I will see the management. So number 2 cases, spastic paraparesis with loss of all motor sensation. Okay. Now I will go to the another case. That is again spastic paraparesis. So spastic paraparesis. Hello, any question?
Yes, sir. Can I ask? Sir,
yes.
This you said spastic with loss of sensation. What about anterior spinal artery occlusion?
Okay, wait for this type.
Okay.
Okay, so now I'll say that spastic paraparesis with anterior cord lesion. Okay, so this is our third case, spastic paraparesis and anterior. Here, while you do the examination, at first I will find that there is a spastic paraparesis in the motor system examination. Sensory system examination is not done. Coordination is not assessed due to weakness. And sensory system examination, there is a loss of pain plus touch. But when we check the posterior column, that is vibration plus position, I will found that is intact. So this indicates there is a only anterior cord lesion. So this indicates there is a only anterior cord lesion. So I will say this on examination of this gentleman, there is a weakness of the both leg, symmetrical weakness of the both lower limb, where distal is more weak than proximal, and flexor are more weak than extensor. And there is also hypertonia, hyperreflexia, and positive pyramidal traction, along with chronos if present. Okay. And coordination is not assessed due to weakness. And sensory system examination reveals there is a loss of pain and touch sensation with intact vibration and position sense. So there is a loss of pain and touch with intact vibration and position sense. So again, so my clinical diagnosis, this is a case of spastic paraparesis with anterior cord lesion or anterior cord syndrome. Okay. They will say what? Okay, so there is a spastic paraparesis with anterior. Okay, so there is a spastic paraparesis with anterior cord syndrome or anterior cord lesion. Look, in the anterior cord lesion, actually, whole of the anterior cord is supplied by the anterior spinal artery, and posterior cord is supplied by the some posterior spinal and sometimes vertebral artery, both. And here the important thing is that if any patient has the spastic paraparesis, they will put in the exam and they will assess the candidate in different way, because here they will put a surrogate, okay, who is also there will be a patient, there will be attendant or surrogate or translator. He will say different thing because he can see the everything. Because you will only see the motor finding. You can only assess the motor finding. But in case of the sensory finding, you have to depend on the patient, or you have to depend on the surrogate or translator, what he says. Okay. So he says a lot of things. So it's possible in one candidate, he will say, I could not find, I don't have any sensation, both anterior column, dorsal column. He can say, yes, in case of pain, yes, I can feel. When I say check the vibration, patients may say, no, doctor, I don't feel it. Because this surrogate is seeing what you are doing. Okay, so he can say everything. So in this way, he can assess the different patient. Okay, so it's very easy. You may find this in your exam. So spastic paraparesis with anterior columnation. So this is the most. What is the cause? So it is your clinical diagnosis. What is the cause? Cause is anterior spinal artery occlusion. So anterior spinal artery occlusion. So vessel may be most common. Most common cause of any vessel obstruction is embolism from the heart. That is embolism. So there is a embolism from the heart, okay, or maybe thrombosis in situ. So there may be thrombosis, and there may be arteritis. That means vasculitis. So those are the causes. So there may be embolism, there may be thrombosis, there may be vasculitis. So if you want to check anything in this patient, you will check the pulse. If you have atrial fibrillation, that indicates there is an embolism. And in case of the thrombosis, actually thrombosis is a large thing, but if you check any patient with thrombosis, there most of the common cases it is associated with connective tissue disease. That means antiphospholipid syndrome, okay, or maybe congenital. Congenital maybe that protein C, protein S deficiency, protein C or protein S deficiency. So connective tissue disease, what is any myelo or lymphoproliferative disease, paired or nocturnal hemoglobinuria. So there are a lot of those, but most common is those. And there is a vasculitis. Again, vasculitis may be primary or secondary. Secondary is all connective tissue disease, infectious vasculitis, malignancy associated vasculitis, or primary vasculitis. So this if the examiner asks the question, he will ask the what is your clinical diagnosis. So this is a case of spastic paraparesis with anterior features of anterior cord transection or anterior cord syndrome. So what is your do you have any differential diagnosis for this finding? Yes, it may be due to anterior spinal artery occlusion. So what are the cause? It may be embolism from the heart source, that is in arrhythmia, atrial fibrillation, thrombosis. For thrombosis, the most common connective tissue disease, antiphospholipid, congenital, myeloproliferative disease, lymphoproliferative disease, PNH, and vasculitis. Vasculitis again is primary or second. So how will you going to manage? Again, general management that include patient education, counseling, explanation of the disease, formation of the multidisciplinary team that involve my consultant, neurologist, occupational healthcare therapist, social worker, physiotherapist, skin care, bowel care, proper nutrition, and specific management depends on the cause. Okay, so he may ask, so what are the common causes of thrombosis? Or he may ask, what are the common causes of embolism? Okay, so actually at that time is differ from a question may differ, or examiner asks in a specific question. Now another case, this is a spastic paraparesis with dorsal columnation. So spastic paraparesis plus dorsal columnation. Again, when you see the going to examine the patient, you will find there is a motor system examination, there is a spastic paraparesis. Sensory system examination, then coordination cannot be assessed due to weakness, or coordination may be normal or abnormal. Okay? And sensory system examination will tell us there is a okay. Sensory system examination, there will be pain plus touch sensation is intact, but vibration position is absent. So what I will say, on examination of this gentleman, I found that there is weakness of the both their leg, where distal is more weak than proximal, and flexor are more weak than extensor. And there is also hypertonia and hyperreflexia. Okay, with positive Babinski sign or positive pyramidal tract sign. Coordination is not assessed due to weakness. And sensory system examination reveals there is a intact pain and touch sensation, but absent vibration and position sense. Okay. So another interesting thing is that in any case of weakness, when you want to see the coordination, actually it will not be perfect because a patient has weakness, so he have problem to sustain hold of the ankle. So sometimes it drops down again. He will try to pull it up again, drop downs of the ankle. Okay. So if any case you will think there is a this type of weakness is possible, then we'll check. You will just after the exam, if you have enough time, just check the finger nose test because cerebellar is specific in the upper limb. You cannot explain or you cannot find the specific cerebellar in the lower limb. Just go to the finger nose test. So this is the hard sign of the cerebellar lesion. Okay, so so this is a case. So what is your clinical diagnosis here? So my clinical diagnosis, this is a case of spastic paraparesis with dorsal column lesion. So spastic paraparesis with dorsal column lesion. So what may be the cause? So here actually cause differ. Here, what are the common cause? Number one is here in this patient actually spastic paraparesis with dorsal column lesion. It's a here patient age is very much important. Okay, so if anytime when we examine the spastic paraparesis, then coordination, you think there is a possibility of some coordination problem, then sensory sextomy you will find there is a vibration or position sense loss, but pain, touch, temperature is present. Then actually you are dealing with Friedreich ataxia. So, but what are the common differential as a whole? It may be due to subacute combined degeneration, maybe due to Friedreich ataxia, it may be due to multiple sclerosis, it may be due to teres dorsalis or teboparesis. Okay. Now, in this case, if any patient I check first, I have checked the motor system, I feel there is a spastic paraparesis. But in between coordination, if you find there is a coordination problem, that indicates cerebellar involvement. When you check the sensation, sensation indicate the dorsal column involvement. Now look all those cases. So what in those specific, you get some extra there. In case of the multiple sclerosis, look, this is the only solely upper motor neuron disease. So you will found here spastic paraparesis plus cerebellar problem. So spastic paraparesis with cerebellar problem. Okay. So because this does not involve the lower motor neurons, there is spastic paraparesis with cerebellar problem. Regarding the Friedreich ataxia, there is all problem of neurology is present in Friedreich ataxia. Okay, so there is a spastic paraparesis plus cerebellar problem plus dorsal column problem plus peripheral neuropathy. In case of the peripheral neuropathy, it always starts from the lower end. Okay, and hard sign of the peripheral neuropathy is loss of jerk, loss of reflex. That I will loss of ankle reflex usually there. Okay. Now again, if you say the subacute combined degeneration, it also present in various ways. Most commonly, if it is involved to the back, then spastic paraparesis. think that subacute combined degeneration now affecting the spinal cord. So spastic paraparesis plus I will found peripheral neuropathy, that is loss of ankle jerk. But it may extend into the up, that is may extend to the cerebellum, may produce cerebellar sign. Okay, so many later we will find the cerebellar sign. So if we found there is a only spastic paraparesis plus cerebellar sign, that indicates this is a multiple sclerosis. If you found this is a spastic paraparesis plus dorsal column lesion plus loss of jerk, that is ankle jerk, it may be Friedreich ataxia if the age is young, and it may be due to subacute combined degeneration. Differentiation in between two is very much difficult, but you can assume from the other thing. In case of the Friedreich ataxia, actually they have all problems. If you do the fundus, you will find there is a optic atrophy. If you see the heart, there is some heart problem. So there will be all problem there. Okay, but so those two is one another differential diagnosis. Another thing is that spastic subacute combined degeneration is monophasic. That is, all thing is going progressively up. But and Friedreich ataxia is also monophasic, but MS is actually sometimes up and down, sometimes up and down. So those are the difference from the others. But subacute combined degeneration and Friedreich, in case of the Friedreich, as it is autosomal disease, hereditary recessive disease, so usually all problems start from the beginning. Okay, so all problems start from the beginning. But in case of second or subacute combined degeneration, I will find progressive sign. Patient is now spastic paraparesis. Now patient is loss of ankle reflex, and another few days later when it go up and extend, it cause cerebral problem. Okay, so what I will say that there's a differential diagnosis. What is there as a mass? There is a differential diagnosis is teboparesis, subacute combined degeneration, Friedreich ataxia, multiple sclerosis. Most of the time, what if any patient of Friedreich ataxia present in the hospital, he will come in your exam. So Friedreich ataxia patient, how I will recognize it is a young patient will be young. Patient will be young. Usually, I will found the patient is 16 or 16 years, but it's very unusual vitamin B12 deficiency at this age. So in case of second, most of the time patient is older patient. But what I will say as a differential diagnosis, I will exclude it by doing investigation. So regarding the then examiner, how we're going to investigate the patient. Again, I will start from the MRI of the spinal cord. Then as there is a peripheral nerve involvement, what I will do, NCS and ENG. In any case of peripheral nerve involvement, I will do NCS and ENG. Vitamin B, MS is there. So again, MRI of the brain will give some clue. CSF will give CSF for oligoclonal band, visual evoked potential for the MS. Friedreich ataxia, I have to do optic fundal photograph to see the optic disc, fundal photograph. Then I will do ECG, chest X-ray, echo to see the cardiomyopathy. And lastly, I will do the genetic test to confirm my diagnosis. This gentleman is also some diabetics mellitus. So I'll do blood glucose fasting 2 hours after breakfast, including HbA1c. So, I will do a lot of investigation here. Lastly, management, again, general and specific patient education, counseling, formation of the explanation of the disease, formation of the multidisciplinary team that involve my consultant, social worker, occupational health care therapist, lots of people. Then specific management depends on the cause. If it is subacute content-dependent degeneration, then I will do the test, vitamin B12 replacement. If it is Friedreich ataxia, actually I will do the symptomatic management for some drug for spasticity, cerebellar problem. And even if it is MS, I'll have to check other thing. either to start biologics or not. So that differs from the cost to cost. So this is the case of spastic paraparesis. Okay. So now something about the spastic monoparesis. So sometime we will found there is a spastic monoparesis. So when I examine the patient, I will found there is a spastic monoparesis. So spastic monoparesis. I will found there is a spastic monoparesis. Immediately, what I will check the patient upper limb. So spastic monoparesis patient. Then what I will check, I will again check the patient back first. I think that I have examined the patient earlier. I have another 2 minutes. Just what I will do, I will check the patient back. Check the patient back. Then I will go the upper limb. Upper limb on inspection. What I will found, if it is most of the time, the spastic monoparesis patient will be acute stroke patient. That is patient of history of acute stroke. Patient is now on getting the physiotherapy, comes hospital to get the physiotherapy. Now patient in the examiner hall. Because in case of acute stroke, it's a devastating patient. He will not put the patient of acute stroke. We'll find everything of the chronic stroke. So patient of stroke, so we'll check the upper limb there with the flex posture of the upper limb. Okay, typical. And then we check what we'll do in upper limb. We will do the only 1 or 2 exam, only tone, power, only tone or power. Okay, or if we think we can check the Hoffman side here. Check. If we check, we can check the Hoffman side. Okay. So in case of spastic monoparesis, if I first of all I will do the examination of the motor system. Then I will examine the sensory system of the lower limb. Then I will check the back. I will check the back every time, because it may be due to Brown-Sequard syndrome, maybe due to trauma or anything, because this trauma only involved that track, one side. So anything will be happen in the back due to trauma. Okay, then I will go to the up. In the up, I can check that there is a flex posture. I have seen already there is a flex posture of the upper limb. Just I will check the tone and power. If there is time allowed, I can check the reflex and Hoffman side. Okay. Then what I will do, I will go, if time allowed, then I will go to the eye, or I will go to the 7th now. But usually time will not permit me. So this is a case of spastic monoparesis. In case of the spastic monoparesis, what will be my differential? So my clinical diagnosis, this is the case of spastic monoparesis without any sensory loss. So I will, in every case, I will say the finding of motor system along with the sensory system. Just like this is the case of atrial fibrillation with fast ventricular rate, atrial fibrillation with slow ventricular rate, because it is a two terms comes simultaneously. Here, spastic or flaccid, that is motor system, always comes with the sensory finding. So my clinical diagnosis is as spastic monoparesis plus without any sensory loss. So without any sensory losses. So what is your diagnosis? Number 1 again is acute stroke. Sorry, stroke. Say, and there will be some. We know there are some differential diagnosis stroke, some structural functional will show everything. So what it may be ICSOL or brain tumor. It may be MS. Okay. Those are the structural. And regarding the functional, hypoglycemia, hemiplegic migraine, conversion, a lot of things. But always we say it may be ICSOL, it may be MS. Okay. And in case of the spinal cord, it's possible of Brown-Sequard syndrome. But in Brown-Sequard syndrome, there will be one side, there will be excessive sensory motor loss, and another side will be sensory loss. Most common cause is trauma. It will not come usually in the exam. So most common cause is stroke. That is ICSOL and MS. That is the structural DT of the stroke. Functional usually does not come in the exam. But we can say that post-ictal paralysis, hemiplegic migraine, conversion disorder. Okay. So again, now regarding the investigation, what I will do, I'll check the brain. I will always check the brain. That is MRI of the brain. Again, for this MS, I will do MRI of the spine, visual evok potential, CSF for the oligoponal blood. Okay. So this is the spastic periparesis without any sensory sign. And there is no case regarding spastic paraparesis with sensory sign. So spastic monoparesis with sensory sign. Okay. Now I'm going to move to the spastic flaccid paraparesis. In case of the flaccid paraparesis, it also comes in two ways, with some sensory sign, without some sensory sign. So with sensory finding, number one is without sensory finding. So first we'll say that without sensory finding. So, we know that in case of the flaccid paraparesis, we'll just again say the same finding. We'll do the same thing. We'll do the inspection. Here, most of the time, I will found some clue. That may be some finding in the leg. There is a wasting, gluing of the finger. So there is a wasting and gluing of the finger. See, if I found there is a wasting but gluing of the finger or toes, that indicates a chronic process. So wasting, gluing of the finger or toes indicates chronic process. So, so and I have said this is a flaccid paraparesis without sensory finding. So what will be the on examination of this gentleman? There is a wasting as well as in clinic case I feel there is a gluing of the finger. Okay? There is a weakness of the leg where distally is more weak than proximal and extensor is more weak than flexor. And there is also hypotonia and hyporeflexia. Or if there is no reflex, there is also hypotonia and areflexia. Okay? And coordination is intact. And apart from this, sensory system examination reveals all modalities of sensation is intact. So this indicates this from what is your diagnosis. So my clinical diagnosis, this is a case of flaccid paraparesis without any sensory loss. Okay, so my diagnosis, this is a case of flaccid paraparesis without any sensory loss. I can extend the diagnosis. I can say bilateral symmetrical flaccid paraparesis without any sensory loss. Okay, but usually it does not miss if I say the paraparesis. So flaccid paraparesis without any sensory loss. Now, what is my differential diagnosis? We say actually this is a very broad differential diagnosis list. So again, flaccid paraparesis, it will be two types, without sensory loss and with sensory loss. So flaccid paraparesis without any sensory loss. So what is it is my clinical diagnosis. Now, what is my differential diagnosis, or what may be the cause? Cause may be number one case is AIDP or GBS. It is acute inflammatory demyelinating neuropathy or GBS. And there is something always related to GBS, that is porphyria, acute intermittent porphyria, and plumboporphyria, that is lead poisoning, acute lead poisoning. That means acute intermittent porphyria, lead poisoning, and again hereditary sensory motor neuropathy. Hereditary sensory motor neuropathy, actually that indicates Charcot-Marie-Tooth disease. It is usually two types, type 1 and type 2. So in one type, I don't know actually which type, I forget this. There is only the involvement of the motor system. predominantly, and another is involving the sensory system predominantly. Okay, so it may be hereditary sensory motor neuropathy. If it is demyelinating variety, if it will involve the motor system. If it is axonal variety, it will be involve the sensory system. So hereditary sensory motor neuropathy. So sometimes we can say this may be also CIDP, but in most of the CIDP, I found some sensory sign. So all these are the causes of peripheral nerve. Okay. So if you go up, there will be anterior horn cell. Sorry, there will be a root. So bilateral motor radiculopathy. So motor radiculopathy. Then I will go up. There is anterior horn cell. Say in anterior horn cell, there is a motor neuron disease. That is a progressive muscular atrophy type, and there is also poliomyelitis. That is not so common. Lastly, if it is acute or patient muscle bulk is intact, I can say there is also myasthenia gravis. Lastly, myopathy, another cause. This is neuromuscular junction problem. And lastly, myopathy, that is myotonic dystrophy. Myotonic dystrophy, but myotonic dystrophy, there is characteristic phases, but maybe some early we can get this finding. So again, this is a case of flaccid paraparesis. In case of the flaccid paraparesis, it may be with sensory sign. Number 2 is without sensory sign. Okay. In case of the without sensory sign, I will say on examination of this gentleman, there is a weakness of the both leg where distal is more weak than proximal and extension more weak than flexor. And there is also hypertonia, hyporeflexia, and absent plantar response. Okay. Coordination is not assessed properly due to weakness, and sensory system examination reveals all modalities of sensation is intact. So my diagnosis, this is the case of flaccid paraparesis without any sensory loss. This is the clinical diagnosis. So what may be the cause? It may be AIDP, that means acute inflammatory demyelinating polyneuropathy, or it may be CIDP, CIDP or AIDP. Most part is acute intermediate porphyria. Again, in porphyria, there is a lead cause, the plumoporphyria. So lead poisoning, hereditary sensory motor neuropathy, Then I'll say maybe motor radiculopathy. There may be anterior horn cell disease like MND. And there may be a myasthenia gravis or myotonic dystrophy. But if we see this is a chronic case, there is a clawing of the finger, there are some wasting. So just in case of clawing of the finger and there is a wasting, this cause will come first. That is hereditary and young patient. So that is hereditary sensory motor neuropathy. And case of the CIDP. In CIDP, actually, if there is a possible patient has previous history of GBS, now there is no improvement, it turns into CIDP. So those cause will come earlier if there is a clawing of the finger and there is wasting.
Sir?
Yes?
Sir, in this you said anterior horn cell, it is MND, yes. And what is the other one, PMA?
Sorry, poliomyelitis, other one.
Yes, sir.
But poliomyelitis is not so common.
Yes, sir.
Okay. Now I'll move to the next. That is a flaccid paraparesis with sensory lesion. So flaccid paraparesis with sensory lesion. Oh, sorry. Regarding the investigation. Now, in case of the investigation, any investigation that involve the peripheral nerve, I will say the NCS and EMG. And here there is a MND, or there may be a myotonic muscle problem. So there is a CPK. I will do the muscle biopsy. I will do the genetic testing. And I will do a specific, then like porphyria, I will do a lot of investigation for the porphyria. Yes, lead poisoning, I will do the investigation for the lead poisoning. But at first aim is to confirm this is upper motor or lower motor neuron lesion. So, or exclude from the myopathy. So this is the first aim. So NCS, EMG, CPK, muscle biopsy, genetic test. By the test, I will exclude it, or I will establish this is a cause of lower motor neuron lesion. Okay. Then I have investigation may be vary for to see any specific thing. Okay. Now I will discuss the flaccid paraparesis with sensory sign. Okay. In case of the flaccid paraparesis in sensory sign, again, what I will say that means by this way I know that this is the case of peripheral neuropathy. Okay, so on examination of the gentleman, this will be chronic most of the time, wasting of the leg, throwing of the finger, high or foot, walking it. For on examination of this gentleman, there is a wasting of the legs, and sometimes there are some tropic changes. There are some ulcer. There are some skin dry, atrophy, loss of hair, blackening of the skin, or loss. All those is tropic change. Okay, so there is a weakness of the leg where distally is more weak than the proximal, and extensor are more weak than the flexor. And there is also hypotonia, hyporeflexia, and downgoing plantar. And coordination is a normal, and sensory system examination reveals there is a bilateral, symmetrical loss of all modalities of sensation in stalking pattern. So findings is motor system is flaccid paraparesis, and coordination normal, sensory system examination reveals bilateral, symmetrical loss of sensation, all modalities of sensation in stalking pattern. So bilateral, symmetrical loss of all modulators of sensation in stalking pattern. So my diagnosis, this is a case of bilateral, symmetrical, distal sensorimotor neuropathy. This is a clinical diagnosis. So this is a clinical diagnosis is, you can say flaccid paraparesis with loss of sensation in stalking pattern, or better to say bilateral, symmetrical, distal sensorimotor neuropathy. So bilateral, symmetrical, distal sensorimotor neuropathy. Or a flaccid paraparesis with loss of sensation, loss of all modalities sensation in stalking pattern. So what is the diagnosis? This is a clinical diagnosis. So main differentiation, this is a case of actually peripheral neuropathy. So peripheral neuropathy, in case it will be in case of the adult, most of the time I will find patient is adult. I will say number one cause is diabetes mellitus, number one is CKD, then alcohol, then drugs, then vasculitis. So in case of the young patient, if the patient is young, what I will say hereditary sensory motor neuropathy, vasculitis, that may be primary or secondary, drug cause, paraneoplastic cause, then alcohol. So it will be differ from the patient to patient. So if the patient is young, I will say hereditary sensory motor neuropathy, vasculitis, drug, paraneoplastic. Then in case of adult, diabetes, CKD, alcohol, drug, again paraneoplastic, syndrome, carcinomatous neuropathy. So all those things is a flaccid, may cause a flaccid peripheral, bilateral, symmetrical, distal sensory motor neuropathy. Okay. So regarding the investigation, here what I will do, again, in case of the investigation, I will do NCS and EMG to confirm this is a disease of the nerve problem. This peripheral, to confirm this peripheral neuropathy and exclude myopathy, NCS and EMG. Okay. Now I will do the other specific investigation. Okay. Like if we say this is diabetic mellitus, older age. So I will check in case of diabetes. What I will say, blood glucose fasting 2 hours after breakfast plus HbA1c. Fasting 2 hours after breakfast and HbA1c. Okay. In case of alcohol, just I also say alcohol history. Then I could do the CBC to see macrocytosis, liver enzyme. Then in case of the chronic kidney disease, again, serum urea, electrolyte, and creatinine, urine for routine and microscopy examination, urea clearance test, calcium, alkaline phosphatase, parathyroid hormone, vitamin B level. So a lot of investigation. It depends on the other cause. And regarding vasculitis, I'll do say only the vasculitis screening. It may be due to autoimmune test. It may be, I will say, I will do autoimmune screening. Okay. So now it will examine the how will management, again, general and specific. General, patient education, counseling, explanation of the disease, formation of the multidisciplinary team that involve my consultant, social worker, occupational healthcare, physiotherapist. Then specific management depends on the cause. And here I will say some causes. There is a peripheral neuropathy. If there is a pain, I will go. I will give some drugs. If there is some ulcer, I will give antibiotic, regular dressing. And if there is any pain, I will give the neuropathic pain management. It is amitriptyline, gabapentin, pregabalin, duloxetine, just like this. So this is the case of peripheral flaccid paraparesis with sensory lesion, that is peripheral neuropathy. So I have discussed the most of the important cause. That is, I have discussed all cases of spastic paraparesis and all cases of the flaccid case. So today I will not discuss anything more. So I will do this next of the discussion after the 4 class. Okay. Then next day I will do the cardiology. Then I will do then again in another day we'll discuss the other parts of the neurology, because it's a complex things and it's actually very big thing. And because I have to say another next day how to examine the cranial nerve, I will do the Parkinson disease and the most common case, just like a ptosis, there is a bilateral ptosis. So I'll discuss in cranial nerve, how to do the examination, what are the most common cases cranial nerve. That is the next class. So do you have any question?
Sir, I just want to thank you. It was very informative session and really very helpful, sir. Thank you so much.
Oh, thank you. Just no one knows actually whenever he will get chance to give exam, because if his exam is cancelling. So what my advice to you, just prepare yourself up to date for the exam. Okay. Just whenever you get the chance, what I think that you will pass in the first attempt.
Thank you so much, sir.
Dr. Shovan, thank you so much. It was very nice. Actually, I was asking you a question and my net connection got lost in the middle about the crude touch. I wanted to know that, is there any condition where crude touch only is lost? Why is it important to check it in the exam? I'm confused about it.
No, we'll just only actually a fine touch, crude touch is that fine touch is comes from the anterior column and crude touch actually part of the dorsal column. So just our aim is to examine the touch. Either it is lost from the anterior side or it's lost from the posterior or dorsal side. So I will just check those signs which is more specific and reproducible, that is pain. And in the dorsal, if I want to see what I will check, I will do the vibration first. So if I get enough chance, always I will check the next time. I can check the touch by cotton, or in the posterior I can do the position cells also. First, my aim, at least I will do the pain by neurotip, and I will check the vibration by I'll check the tuning fork. So I will do this.
So you said fine touch in the anterior and crude in the posterior, right?
Yes, there is some difference there. Yes.
Okay, and with cotton wool, we are checking crude touch, right?
No. I don't remember, but it may be due to fine touch.
Okay.
But I will not going
Opposite
to
is
check
the
this.
true.
It's the
Oh,
light touch.
yes.
By cotton is the light touch.
Light touch, yes, light touch. Thank you.
Yes, cotton is the light touch, other one is the pinprick sensation. So both are different in a way that cotton wool sensations, they come from the anterior, and the pinprick, they come from the lateral column. So combined together, that is actually the anterolateral column, which is
Yes.
which we are testing. Yeah.
Yes, thank you. Yes, you are right.
Thank you, doctor. It was very nice session.
Thank you. So thank you, everyone. So hope we'll meet in the next day. Assalamu alaikum.
Walaikum salam.